emergency medicine channel. Sir, shall we?
Yeah.
Today we are going to discuss a case of breathlessness.
Okay.
A 60-year-old man, known case of type 2 diabetes, hypertension, presents to the emergency department with breathlessness and chest pain of 2 days duration.
Okay.
On our initial 10-second assessment, the patient was conscious, oriented, and obeying commands. Coming to the primary survey, airway was patent, no hoarseness, gurgling, or stridor was present. Coming to breathing, the respiratory rate was 30 per minute and the saturation was 90% in room air.
Okay.
At this point, we made the patient in proper position and O2 was started via nasal prompt.
Okay.
Coming to circulation, the pulse rate was 110 beats per minute, BP of 150 by 90 millimeters of mercury.
Okay. Anything else you examine in the respiratory system? You said the primarily this patient is having a acute onset, not acute onset. Since 2 days, he is having breathlessness and chest pain. So anything else that you wanted to add in your breathing? You said regarding respiratory rate, it is 30 per minute. It is definitely the patient is having tachypnea, and saturation is 90%. You have initiated on oxygen. Any other examination that you wanted to do at this point of time in breathing?
Sir, air entry.
Air entry has to be. Air entry bilaterally
equal.
Air entry bilaterally equal or decrease? What is the finding?
Decrease on the left side. Sir.
So air entry was decreased on the left side. So right now we have a patient, 60-year-old gentleman, who has come with history of 2 days onset of chest pain, breathlessness, and on assessment you found out that his airway is patent and he is having a respiratory rate of 30 breaths per minute with an hypoxia, that is saturation of 90. So approximately PO2 will be around 55-60. So that is a PO2 for him, and you have initiated him on oxygen, and auscultation there is decreased air entry on the left side. So left exactly, can you tell where exactly on the left side, or totally the length field left side it was diminished?
Left side, most of the part it was decreased.
Decreased. So with this in background, what all things you will think of as the differential diagnosis?
So this patient present with an acute onset breathlessness and chest pain.
Acute onset in the sense it is 2 days.
2 days.
2 days. Acute onset means something within hours. You can tell. In emergency room, within hours we can, minutes and hours we can call it as an acute. It is like it's within 2 days he started developing breathlessness. And what was the progression of the breathlessness? Is the intensity is the same, or it has increased, or it is remaining the same? That is the next question that I want to
ask. So it was gradually progressive. Initially it was like an MMRC 1 or 2.
Okay.
And gradually progressed, and at the time of arrival it was MMRC 4.
Okay. So initially to start with it was a mild breathlessness. Now it has increased. Okay. 1 to 4 MMRC. Okay. So with this background, you have checked for the circulation. We'll just keep the respiratory system evaluation there. Then we will do the full primary survey and we'll go to the differentials.
Coming to circulation, the pulse rate was 110 beats per minute. BP of 150 by 90 millimeters of mercury.
Okay.
All peripheral pulses equally palpable.
Okay.
At this point, we have inserted 2 large bore IV cannulas. Disability wise, GCS was 15 by 15. Pupil bilaterally equally reacting to light.
Okay.
Exposure wise, the temperature was 100.2 degree Fahrenheit, GRBS of 160. In view of hypothermia, we have given injection paracetamol 1 gram IV stab.
Okay. Now I'll ask you just a question. You said since you said that this patient had hypothermia and you gave paracetamol, whether or you have to give IV paracetamol? Whichever condition, okay, we can give IV paracetamol. I am not denying the fact you have given IV paracetamol. Whichever conditions, IV paracetamol is definitely indicated. Where it is indicated, we give left and right IV paracetamol. Because the cost effectiveness is also one important thing. If the patient is able to take orally, we can give 1 gram oral paracetamol also. Time of onset will be a little bit more, but here since the patient is breathless, maybe oral intake will be poor, you are given as an IV. But definitely we're all okay. This patient requires an IV paracetamol. Can you just tell me a few conditions where it is definitely indicated for an IV paracetamol?
So one condition is definitely the patient is not able to take orally.
Okay. Okay, fine. Then we can give IV paracetamol also in that condition. So overall IV paracetamol is definitely indicated. See, you have to understand that associated with atrial fibrillation. Okay, the patient is having an arrhythmia and it is associated with fever, that is for cardiac failure. You can give paracetamol IV. So that is indication number 1. Then indication number 2 will be pregnancy and fever. The patient is having Patient is pregnant and is having fever. So pregnancy and fever. That third condition, hyperthyroidism. The patient is a known case of hyperthyroidism and he has come with fever because they have potential to develop of arrhythmia is poor. So those group of patients you can give IV paracetamol. Then which will be the other category of patient. Stroke patient, acute stroke patient where we wanted to avoid hyperthermia. So these are the classical indications where you can give IV paracetamol. So these are the conditions where IV paracetamol is definitely you need to give. So I'll just brief out to you again. Can you just list it down? What are the one thing? One will be hyperthyroidism. Hyperthyroidism. Then two will be. Second one will be
acute stroke.
Acute stroke or acute any head injury, any raised ICP that you are having, acute stroke or anything, acute head injury. Third one will be pregnancy and fourth will be associated cardiac failure or arrhythmia. So these are the conditions definitely we have to give CCF, you can just cardiac failure. Yeah, you need to give IV paracetamol. So generally we give IV paracetamol for a lot of other conditions. But these are the conditions where you should give IV paracetamol. We hyperthyroidism, we don't want them to go in for an arrhythmia. Already they might be on some anti-thyroid drugs. So they may come with thyroid storm. So at that time hypothermia we need to get it controlled. So we need to give IV paracetamol for these conditions. So these are the general definitely indication, but we will give it for pain management, we will give it for fever management, if we give it for satisfaction for the patient, all those things we practice, but definitely you should know what are the definite indications for giving IV paracetamol. Continue.
Coming to the actions of primary survey, ABG was taken, ABG showing a pH of 7.3, PCOH of 41, bicarb of 23, POH of 78 and lactate of 2.3.
Okay.
No acute acid-base disorders as per ABG.
No acute. 7.3 is it normal?
Slightly on the acid.
So definitely it is not normal. So 7.3 pH is not normal. 7.3 pH definitely it is not normal. See, you have to understand one thing. What will happen when the patient is breathing faster? What will happen to the carbon dioxide?
Washout.
Carbon dioxide washout has to happen. See, what is the PCO2 level here?
41.
41. What we are expecting?
Alkalosis.
Alkalosis. So it is going to be less than 35. So according to what our clinically we are seeing, it should be on the lower side, but it is not on the lower side. Bicarbonate 23, you can take it as near normal bicarbonate. But even if you look into 7.3, there is some primarily an issue is going on. It can be either the patient is going for an early respiratory acidosis or a metabolic acidosis because he has not compensated at this point, decompensated at this point of time. But there is definitely hyperlactemia evident by more than 2.3. So more than 2 lactate we can call it as hyperlactemia. So here lactate is already on the higher side. So lactate is 2.3 and pH 7.3. First I wanted to know. If it is 7.34 then it is borderline, but 7.300 it is definitely on the lower side. But PCO2 of 41 definitely it is going to be, we are anticipating a lower PCO2, but here it is on the higher side. Okay. Then
CBC CRP was done.
Comment about PO2. So PO2, whether the PO2 was with oxygen or without oxygen?
With oxygen.
With oxygen it is 78. So that is again very concerning for us. So you are given some 4 liters of oxygen and still the PO2 has gone up only to 78, which is the normal limit with oxygen. So definitely this patient is having hypoxia. So whenever you are commenting regarding ABG, don't just say the acid-base disorder. We always forget this hypoxia part. Hypoxia has to be said, hypoxia and associated with acid-base disorder you need to comment. So that is always you need to look into. Okay, then.
The CBC CRP was taken and CBC showing a total count of 18,000 and CRP of 186.
Okay, so that definitely point about, so it's a shift to left. Some acute inflammatory, it can be associated with fever. We can go into the sample history, we will know to that. If it is associated with fever, definitely we are dealing with some infective etiology. Otherwise, we have to look in for other differentials.
ECG was taken and was showing sinus tachycardia.
It was showing sinus tachycardia. While you are saying sinus tachycardia, there is a P wave here. That is followed by a QRS complex. And what is the heart rate here? Calculate the heart rate here. What is heart rate that you can calculate? It is somewhere around 140. It is 300 divided by 300. We are able to see 300 divided by number of large squares between two RR intervals. So it is somewhere around 2.2 you can consider. So around 130, 140 will be the heart rate. So that will be the heart rate of this patient. So that is the what you are able to see in here. Then each P wave is formed by a QRS complex. There is no STT changes here. You are not able to see any STT changes. It is normal. It is all STT is normal. But you are able to see something here. He is a known hypertensive.
Yes, sir.
Hypertensive. So what does that indicate? When there is some amount of left ventricular hypertrophy, so this patient, he might not fit into all the criteria of left ventricular hypertrophy. Maybe echo you do, definitely it is going to be, you will be able to see some left ventricular hypertrophy. So this one is again significant. V4 and V5, if it is both the QRS complex are merging together, that itself you can take it as one criteria for left ventricular hypertrophy. So this patient might be having a left ventricular hypertrophy. Okay, so acute onset breathlessness. You have taken an ECG. Why you want to take an ECG? That is my question. Why you wanted to get an ECG for this patient? So reasons one, this patient had a chest pain. So chest pain, we have to rule out ACS. So ACS we need to rule out. Reason two, why you wanted an ECG?
So we can also look for S1 Q3 T3 change.
S1 Q3 T3. How long? How many how many percentage of patients with pulmonary embolism will have?
10%.
It is only 30% of the patients will have S1 Q3 T3, and that you can call it as, what is the name of that sign? What is the name of the sign? McGinn-White. That is the name of the sign. McGinn-White sign. When you are able to see S1, that is, you are able to see an S wave in lead 1, then Q wave in lead 3, and T wave inversion in lead 3. So that is S1 Q3 T3. It can be seen in pulmonary embolism, but only in very few patients you are able to see S1 Q3 T3. But what is the most common finding that you will be able to see in a patient with pulmonary embolism? This sinus tachycardia. He is having a sinus tachycardia, chest pain. But what is not fitting for an pulmonary embolism? What are the any risk factors for pulmonary embolism he has? Was mobile. There is no malignancy. Obesity. He was obese? No, he was not. So the risk factors are not there. So pulmonary embolism, even if he will have, but the chance of pulmonary embolism having is less. We can do with whatever scoring system is pulmonary embolism, rule out criteria, Wells criteria, all those criteria we can look into, but chance of having a pulmonary embolism is low. But again, with chest pain, pulmonary embolism definitely will be one of our differential diagnoses. So, with this history, can you list down your differential? Differential number 1. What is your differential diagnosis 1? Patient. We can maybe after this thing, sample history we will go. So it will be much more easier for you.
Then we have also taken an X-ray.
X-ray.
Chest X-ray showing a homogeneous radio opaque shadow in the left lower zone of the lungs.
Okay.
And also a mild tracheal shift to the right side.
Okay. So the trachea is shifted to this side. Okay.
So probably suggestive of a pleural effusion.
Okay. See, what you can see from start viewing the X-ray. One thing I will say that I am not able to see the CP angle. So I need to see both the CP angles. I am not able to. This is a little bit rotated film also, because in AP view you cannot expect to have everything. But this is a little bit of rotated. You are unable to see this right CP angle. But what is very obvious here, this area, there is a homogeneous opacity. This area, there is a homogeneous opacity, and you are also able to see something like a level like this. So level like this. When it is a consolidation, you will not be able to see something like a level like this. So you are able to see some fluid level getting accumulated in that side. So that can be part of your pleural effusion. I am unable to see any air bronchograms. If you are able to see an air bronchogram, it is suggestive of a consolidation. So what you can see, a left-sided, you said left-sided air entry was less. So left-sided homogeneous opacity occupying almost half of the lung field on the left side. And there is a fluid level, and there is little bit of shift of, usually the trachea will be slightly deviated to the right side only, but here there is some more shift of trachea to the right side. Maybe due to this pleural effusion there is a shift, or it can be part of your rotation, but trachea usually don't shift with your rotation, but there is some amount of shift of trachea also. With this X-ray, we are probably our differential diagnosis, we have narrowed down it as pleural effusion. One differential diagnosis is pleural effusion. Whether it is just a pleural effusion or something else, along with something. Why he can develop a pleural effusion within 2 days history?
So on top of any pneumonia,
it can be, and basically to start with, it can be just a pneumonic effusion, or it can be tuberculosis or malignancy, which we don't know. We just need to go with the further history. So sample history you can present, then we can go to the differentials.
60-year-old male, known case of type 2 diabetes, hypertension, present to the emergency department with complaints of breathlessness and chest pain of 2 days duration. Breathlessness is gradual, progressive, and on arrival it was MMRC 2 to 3.
Okay.
No orthopnea, paroxysmal nocturnal dyspnea, syncope, or edema.
So that somewhat rules out as CCF. So this one somewhat rules out as CCF. With PND, orthopnea, and or mitral. What is classically this paroxysmal nocturnal dyspnea? How will the patient come? How will you ask the history for?
So in the middle of the night, the patient is having severe
breathlessness. The patient might have went for sleep. So after some time, the pulmonary hypertension increases and patient suddenly wakes up from the bed and he went to the window for getting some fresh air and he improved. So that is a classical history of PND. Why you wanted to add syncope in that? What is the significance of you added a syncope? Negative history. Why syncope?
Some features of cardiac failures.
Cardiac failure, syncope. How frequently you are able to see syncope? See, along with the associated as aortic stenosis, we are having an aortic stenosis and syncope history, it is very significant. Okay, then edema. Chest pain, you can elaborate on chest pain now.
Chest pain, pleuritic chest pain, left-sided, aggravates on deep inspiration and cough.
Okay.
No history of any radiation, sweating, or palpitation.
Okay, so that is very important. So he is having a pleuritic chest pain. Why you said it is pleuritic? It is localized. He is able to say where exactly the pain is. He is able to pinpoint the pain and aggravates on deep inspiration and expiration and on cough. So that is again classical of your pleuritic chest pain. So again, from whatever you have seen the X-ray, definitely there will be some pleural irritation. So on top of that, he is developing this. So that is the reason why we have taken the history. So the chest pain here is more in favor of a pleuritic chest pain. So unlikely to be a cardiac cause of chest pain. Okay.
The patient also gives history of fever and a productive cough.
Okay, so there comes fever and productive cough. Okay.
No history of any evening rise of temperature, loss of weight, hemoptysis, hoarseness of voice.
So we have this history you are asking for your tuberculosis. So pleural effusion you are seeing, whether we have to rule out a TB, we have asked for that history. So we can narrow down our come to our differential. You can know history of any allergies. Is taking medication, telmisartan and metformin. No similar illness in the past or any significant family history. Examination, nothing significant. Self examination. Respiratory system. We have chest movement decreased on left side. Trachea shifted. Accessory muscle of respiration. Decreased chest movements on the left side. Auscultation, birth sound decreased on the left side, which already outside, and percussion also dull note on the left side. Okay, so we have seen the X-ray, so our differential diagnosis is a little bit more easier. Other system, everything on normal, no markers, anything. Okay, so final diagnosis, you have put it as a left-sided pleural effusion, possibly infective etiology, not in respiratory failure. I think he's in respiratory failure, no? He's having hypoxia. You are supplementing him with oxygen. So he is still not in respiratory failure. In respiratory failure, functional status bedridden because he is having breathlessness with underlying type 2 DM and hypertension. Now the question arises is, you have said we are dealing with a left-sided pleural effusion. So left-sided pleural effusion. So what will be the management plan for him? So how will you treat this patient? So this is, I think it is more in favor of a pneumonia, pneumonic pleural effusion. So how you are going to deal with this patient? So what are the investigations that you will order for? When will you do a pleural fluid tapping? Whether it is mandatory to do here, or you will wait for some days, or whether you need to do a CT scan for this patient. So these are all the questions. What are medications that you need to give? So here the history is very clear. That is one thing I want to say. He is having fever, cough, breathlessness. So it is more in favor of a consolidation along with some pneumonic pleural effusion. But pleural effusion, we are able to see majority of your chest X-ray. Maybe there will be an underlying consolidation also, which we might be able to get by help of an ultrasound. By keeping an ultrasound, you can look for that. Or else, you have to get for a CT scan for definitely looking for the consolidation. Now, my question is whether you need to tap this pleural fluid or not.
We can do a diagnostic tapping, sir. And
Okay.
send for TCDC and.
So, what are the investigations that you need to send him in the pleural fluid? Can you elaborate? You can just write it down. So, we can keep it a little bit long. Yes. Pleural fluid analysis, total count, differential count. Then
you can also send for pleural fluid for cytology.
Pleural fluid for cytology. We have to rule out any malignancy. We can do that. Then
gram staining.
Gram staining. Okay.
AFB.
Gram staining, AFB. You can also send something called as a gene expert. Gene expert. Gene expert for TB. Then what is the other investigation that you wanted? Whether you wanted to know it is in
send the cultures.
No. What are the different types of pleural effusion? It can be exudative and transudative. So here more looks like an exudative from whatever history. So how will you confirm an exudative pleural effusion? LDH and proteins. Yes. So you have to look for TCDC, protein, sugar, LDH. You have to look in for, and this is a basic investigation that you need to send in for your pleural effusion. ADA also fine. So where will you do the tapping? That is my question again. Where, when, and where. See, there are two reasons why you want a pleural effusion to be done for this patient. One thing, if you remove some amount of fluid, it can relieve this distress. That can be one reason. But also here it is diagnostic. We are not very sure what is causing this pleural effusion. Whether it is in any tuberculosis or any other things, we will be able to understand it better. But with 2 days history, maybe a small pleural effusion was there for a long time. Maybe there was a gradual worsening and everything worsened and he came in. But there is no other history suggested. There is no evening rise of temperature, nothing is there. Only 2 days history is there. So most likely it is be an acute bacterial infection leading on to a consolidation with the pneumonia effusion. That is the most likely to be the differential. But here, by doing a tapping, we can rule out one of the other differential diagnoses like malignancy. We can rule out and TB, all those things, and we can get some diagnostic clue also if it is an exudative or transudative. So, what criteria we will use is the
Lights criteria.
Modified Lights criteria. So, can you just write it down the modified Lights criteria? Pleural fluid protein divided by serum protein more than 0.5. Pleural fluid LDH, serum LDH 0.6. Pleural fluid LDH more than 2/3 of serum. What is it? Serum? So what you have written? Pleural fluid?
Glucose.
Yes. Should not be any confusion. Pleural fluid, G you this right. Sugar more than 2/3 of the blood glucose. So, what is the if it is more than this, what you will call it? Which is exudative, which is transudative?
If any one is positive, then it is an exudative pleural effusion. So
okay.
All the three are negative, then it is a
transudative pleural effusion. So by this we will be able to say whether it is a transudative or an exudative pleural effusion. Was done for him?
It has been sent, sir.
It has been sent. So the results are awaited. So now my this thing again, my query will be: you have done for this. Now, how will you treat this patient? You need to treat him. So yes, we were cough, breathlessness. There is pleural fluid you have tapped, but you have to treat the issue. So what is the? How will you go about the treatment for this patient?
We can start the patient on IV antibiotics.
IV antibiotics. So how will you select the IV antibiotics for him? What is the group of bacteria that we have more likely to be bacteria? It is consolidated to one area, so more likely to be a consolidation with some amount of pneumonia. Usually viral, it will be a bilateral. It will be in between bilateral infiltrates. Bilateral picture will be there, but it's more to a consolidation, what we are, maybe a bronchopneumonia with the pneumonia effusion, or it can be a, what else it can be? What is the other possibility? Interstitial pneumonia, unlikely. Interstitial pneumonia is bilateral again. So, how will you treat this patient now? What antibiotic you will choose?
We can ideally start the patient on ceftriaxone and some.
Okay, so my question: what all organisms you need to cover? Let me ask you first question. Which organism you wanted to cover? He is coming from another hospital or he is coming from his home? He is coming from his home. So he has not received any antibiotics. So he is coming from the community. So we are dealing with probably a community acute pneumonia with associated pleural effusion. So that is what pneumonia effusion we are dealing with. So since he is coming from the community, we are not very concerned regarding the resistance at this point of time. When he is coming from another hospital, we need to think of resistance. So that is one. The next thing, whether he has got any comorbidities. So most commonly, which are the organism causes infections? Which are the more common? Gram positive. You can just broadly we can say it is gram positive. Atypical, it will be not like consolidation, it will be bilateral picture and they will have atypical symptoms. It is here, fever, breathlessness. It is not an atypical pneumonia, it is a typical pneumonia. Typical consolidation with pleural effusion. So we are going to deal with possibly a gram positive infection. But since he is a diabetic also, gram negative also, we need to have a coverage. So we need to select an agent which has got a gram positive coverage and has got a gram negative coverage. So that will be my aim to start off with. So which agent you can start off for a patient. So for example, you are starting on augmentin. Suppose you are starting on augmentin, it's a very good drug. If you just wanted to give a gram positive coverage, penicillin, augmentin, any of this is very good. But I need to have some of gram negative coverage also. So gram negative coverage, you need to start with either of the cephalosporins. Or even if you want to give a single drug therapy where it has got very good gram positive, gram negative, and atypical, levofloxacin is there. But problem with levofloxacin, here it has got anti-tuberculous effect also. So if we are having a TB patient, by giving levofloxacin, we are masking that. So ideal agent will be a cephalosporin. You can start with maybe a ceftriaxone to start off with, and you can see how the patient is responding. Then you can think of escalating. But right now he is coming from the community. Suppose he is coming from another hospital. He has 3 or 4 days he has been getting treated. He is not improving and coming to you. So that definitely at that point you need to think about resistance and pseudomonas and all other hospitals. At that time, you need to give a coverage of an antibiotic which covers for that. So at that time, I'll be choosing a penicillin which has got gram positive, gram negative, and also pseudomonas, antisomal like piperacillin sulfactam, ticaracillin clavulanic acid. If you said regarding ceftriaxone sulfactam, it is a good agent. I am not denying the fact. Ceftriaxone or ceftriaxone sulfactam can be started, but what agents that we need to cover is our priority. So suppose it is pseudomonas that you want to cover. He is coming from the hospital. Pseudomonas always we plan to give dual coverage. That one you can remember. So one is an anti-pseudomonal penicillin like piperacillin sulfactam, ticaracillin clavulanic acid. Plus you can give either respiratory, any of the respiratory quinolones or aminoglycosides like amikacin or any of these agents we can give. Suppose he is again on a ventilator for a long time. So ventilator associated pneumonia, we have to think of gram positive resistant organism like MRSA. So at that time we need to add an vancomycin or linezolid. That is how we have to plan the antibiotics for him. He is coming from the community. At the present, we can just start with the. You can what drug you have said. You can just add on. We can write first drug that you wanted to give. You can give with ceftriaxone sulfactam. You can ceftriaxone sulfactam. Or what is the dose of ceftriaxone sulfactam you want to give? So ceftriaxone sulfactam, ceftriaxone with sulfactam. Sulfactam. Dose
2 grams.
2 grams stat you have given, and you can continue on a BD dose or an OD dose depending upon the renal clearance. All those things you can decide further. So it is to be given after test dose. So what is the next thing? So you have given an antibiotics for him. So you have done a tapping for him, and you have given an antibiotics for him. So what is the next thing? He has got some pain. So you have to manage his pain. We can give paracetamol. Since you have an oral paracetamol is well and good. Maybe around the clock 650 tablet of paracetamol you can give. Or if the patient is not able to tolerate, you can give IV preparation. So analgesics, you can just put analgesic. You have given analgesics. Analgesics. Then suppose the sister is coming and telling you that you have done the tapping. Yeah. And after 3 hours the sister is coming and telling you the patient is breathlessness, increased breathlessness. What will you do at that point of time? You're done your tapping and patient was comfortable. 3 hours later, the sister is coming and telling you the patient is having more breathlessness. So what do you do?
It can be either due to reperfusion edema that can cause.
Okay, so it all depends upon how much fluid you have aspirated. 750 to 1 liter is the usual target. If you are targeting more than that, there can be this reperfusion, edema, pulmonary edema can happen. What is the other problem that you need to anticipate? Reperfusion pulmonary edema usually happens within like 1 or 2 hours. What is the other complication that you can anticipate? Pneumothorax. So definitely one thing that after procedure get a chest X-ray. Mandatory to have a chest X-ray. So we have to order for a repeat chest X-ray. Chest X-ray repeat. So you have done one X-ray, but you have to repeat a chest X-ray also to look for any, for that matter, after intubation, putting a center line, after a tapping, your pleural tapping, definitely get a chest X-ray. Then what will be the other thing? Blood sugar control. What is your target blood sugar control that you wanted to achieve in this patient? Any patient in the ICU target around 150, 180. So that is a blood sugar target. So target will be 150. Glucose target will be glycemic control. So for glycemic control, he is already on metformin. So I prefer not to give him on metformin because lactate is a little bit on the higher side. I don't want any lactic acidosis also to come up. So preferably, what do you need to start him on a short-acting insulin. So you can put some 6 to 10 units to start off with, and depending upon your target, you can have to increase the insulin requirement. Then hypertension, this routine medication, telmisartan. So we need to continue him on telmisartan and oxygen support. Whatever is on, he should continue on his oxygen support. So suppose after like 8 hours, you are starting him on oxygen, its saturation is not improving. It's still on the higher, on the lower side. So what will you do? The respiratory rate is around 25. So saturation is 90, 91. He is not a COPD patient. So what will you do at this stage? You have increased oxygen to by a phase response to 5 to 10 liters. Still the saturation is 90, 92.
Positive pressure.
See, positive pressure ventilation. Here there is another option also which we haven't discussed much. There is something option common, high flow nasal cannula. So a type 1 respiratory failure will be an ideal candidate for a high flow nasal cannula. If you want a positive pressure also, then it is not a good option. But for this patient, maybe an early acute lung injury or maybe an early ARDS, if there is no PCO2 retention, we can definitely go for a high flow nasal cannula. Starting with a flow rate of 40 liters per minute, you can start for it. So that are the options that is available. Okay. So what all we have discussed here? We have discussed for an acute onset breathlessness. This gentleman has come with 2 days history of fever, cough, chest pain and breathlessness, gradually worsening breathlessness. Any sputum production was there? Mild production was there, and he's a diabetic and a hypertensive. So we assessed him and we found out that he has got a left-sided pleural effusion. We have done a tapping, we are awaiting for this report. Depending upon the report, we will decide whether it is an exudative or transudative. From whatever history is available, looks like an exudative pleural effusion secondary to an underlying pneumonia which has caused this pleural effusion. So we have, for time being, we have started him on an antibiotic. Since he is coming from the community, we have started him on a gram positive as well as a gram negative. Being a diabetic, we doesn't know his diabetic control status. So we are covering for a gram negative coverage also. Analgesics, repeating a chest X-ray after the procedure, look for any complication, glycemic control and hypertension management and oxygen control. So that will be the time management. Depending upon the result, we will decide further. You have anything else to add on? You have put on some slides? Nothing. That's it. Okay. Okay. Thank you.